Hi everybody, and thank you for the invitation to speak. I guess we're the loners in the group. We're sort of on our own, doing slightly different things, slightly different contexts. So I always like the opportunity to remind everybody that it is a bit different. The scale is very different, so the number of new patients is very different. Those diseases represent about 80% of the patients we see. So ALL obviously is the most common childhood disease, but that's only 50 to 60 new children a year. So the disease groups are really, really small. And the number of children who are relapsing, which is obviously the most important metric perhaps, because we want to try to stop people relapsing because then they're cured, and we want to try to treat them with less toxic medications. Important also just to maybe go back to the history of what we used to do, which is, I think, probably similar to other people, but we have one centre. The Cancer Trials Unit was set up in the hospital, was relying on the credit matrix, but we had national and site duties. So for every trial that is opened, we have to go through the national processes. We have to open as the site duties as well. The vast majority of our trials are academic, so pharma funding is near zero. And the other maybe big difference is that the vast majority of children are treated as an inpatient, so it's the standard of care treatment. And so we're relying on the staff of the hospital, the normal clinical staff, to deliver clinical trial care, essentially. The hospital has traditionally provided 3 staff, but we were relying on the CTI funding, or the ICORG funding as it was. And as some other people have mentioned, we were essentially competing with ourselves for this grant, because who else was going to do paediatric clinical trials? And we lost, because a one-horse race, our revenue dropped by 30%, because we had to work with an academic partner, which we had never done before. And at the same time, the hospital had to develop a relationship for their CRF, essentially, which was it was essentially non-existent. So now we have the clinical trials unit and the clinical research unit in the hospital with 2 different academic partners. So we're paying the overheads to 2 different universities, and we're doing all of the work, because all of the HR and all of the other bits go through the hospital. So the UCD folks are very nice, and we get on very well, and maybe the one benefit of it is that our reporting financial matrix is very straightforward. So Paddy, if you want to come and work in paediatrics, that'll save you a lot of stress, because my reporting responsibilities are pretty small in terms of the numbers. So that is our big challenge, is that we had to keep going with the same level of trial activity but less money. And of course we've negotiated some return of the overheads, but it's an extraordinarily inefficient way to do things. I don't have fancy graphics because we're spending all our money on other things in CHI. But as you know, CHI exists, and you could use all sorts of adjectives to describe the process, but it is very complicated. So we have a new research office, we have 3 hospitals working together, and it has been very challenging at the same time as recovering from COVID, the cyber attack, and the shortage of staff. I've decided to go challenges first because I'm also optimistic, so I'm going to finish with the successes, just in case you're worried. The pay scales was a huge issue for us, because a lot of our clinical trial staff were employed on fixed-term contracts through the National Cancer Research Facility, where the pay, say the obligations of the employer weren't as beneficial as the HSE, and then we had to switch to the HSE scales, which introduced more costs, and we had to revise the budget and use up our rainy day fund. Pharma don't want to talk to us because we're so small. Other people have mentioned these challenges, and it's great that Donal is working on this, but paediatric GDPR is an absolute nightmare, and it takes a lot of time. The hospital has not invested in this properly. The switch, so in the old days, a trial, we would want to open an academic trial. It's for the good of kids. We're going to be treating them as inpatients. Everything will be done appropriately. We would go to the CEO, they would sign the contract. We had our own internal ethics committee, and we would open the trial within, I don't know, was it 42 days or something that Donald said? It was extraordinarily fast. And now we are probably the slowest institution in the country at opening trials. So the learnings, it takes an awful lot of time to do anything and to change anything. The cost of running clinical trials, and this is pediatrics, is extraordinary. So this is a very crude measure based on the number of staff that we employ for the number of children that we treat on trial, which has nothing to do with hospital costs or drug costs or scan costs or time of the clinical staff, and it's about €10,000 per patient per trial, per enrollment. We feel that the paediatric grant needs to be different because our metrics are very different. So they've designed the reporting matrix for a factor of 10 or 20, and that's why our reporting is so straightforward, because the numbers are really small, and we tell them, well, it's pediatrics and this is really good. Essentially, we were enrolling about 50% of the children who presented on a clinical trial, and it has taken us 4 years to get back to that. So thankfully, we now have, I think it's on the next slide, but we have 17 trials open. 8 of them are a treatment interventional trial. Altogether is the new acute leukemia trial, and we've enrolled, I think it's 70 children since January last year in that trial. We've also just opened a molecular profiling trial, so this is whole genome sequencing, RNA-seq, the full shebang for all children who present with cancer and at the time of diagnosis and relapse. So this is a major step forward in pediatric cancer research. We have a new compassionate access trial because, as many of you know, there are about 4 drugs licensed for use in pediatrics, so we use a lot of off-label drugs, and we need to report that, particularly in the environment and the letter that the HSC has recently circulated about these medicines. We've completed CETUS transition, which was a huge burden as the national centre, so we had to transition all of the open trials, all of the old trials. We had to close all of the old trials under the new CTR. And our staffing levels are near full. Thank you.